This bit is mostly about treatment and mostly about medication treatment, so I'm going to go through it reasonably quickly, because even though it sounds like there are only 2 people in the room who might be actually prescribing, but the rest of you, I'm sure, will meet people who are on the medications, and it's useful to know a wee bit about it. So guidelines are useful, but often guidelines for treatment, like the NICE guidelines, talk about things that aren't necessarily easily available here, like cognitive behaviour therapy and interpersonal therapy as options before medication. We often can't actually access those. So with any medication during pregnancy, a discussion with the woman and other interested parties is useful, so that the woman herself can make the decision as to what weight she wants to put on the risks and benefits of medication or other courses of treatment. One of the things that often happens is that someone tells the woman to stop the medication because she's pregnant. And as recently as Friday, I saw someone who had, well, she wasn't even pregnant, she just thought she might be, where the GP had told her to stop the lithium before a positive pregnancy test, and she had become quite elevated, had presented to ED saying she was pregnant with abdominal pain. She wasn't even pregnant, but had become unwell because the lithium had just been stopped. So if you've got someone on a medication and you're not sure about it when they present to you with their pregnancy, ask somebody rather than saying stop it. So the risk of deterioration is one of the things you're going to need to weigh up if someone's already on medication during pregnancy. And the things to take into account are the severity of the condition. If they were psychotic and suicidal, you're going to have a real high threshold for reducing or stopping the medication. Their current mental state and for how long they've been, however they are at the moment, whether it's something that has relapsed several times, and also how much support they've got. So what do we know about depression and pregnancy? And of course there are a few meta-analyses. Some studies indicate that there may be an increase in miscarriage. I know sort of single case studies of a woman who had repeated miscarriages. We treated the depression, she carried the baby to term, but that's a N of 1, that study. Effects on the baby's growth. You've also got to look at things like drug and alcohol use, including tobacco, nutrition, other things that may be impacted by the woman's mental state. Preterm delivery, possibly increased in women with depression and anxiety. Clearly I've got this from some small study of the neonatal effects, which seem to be, reasonable neurological, that there are some things that go on when the mum's depressed and not treated. I've said here long-term effects unclear, and indeed about depression during pregnancy they are, but as I mentioned before, there are some pretty clear effects right up till adulthood. And I talk a little bit more about this in the Pacific part of the talk. So SSRIs in pregnancy. We know that, again, there's nothing really robust. There are some indications that there may be problems, but also what's due to the depression, what's due to lifestyle factors, what's due to the actual medication itself. What we do know is that paroxetine, when used in the first trimester during the period of cardiogenesis, is associated with septal defects in particular, and so it's recommended that we don't use paroxetine. There have been single studies that say there may be problems with other SSRIs, but paroxetine is the only one that we've got robust evidence about. Fluoxetine has been around the longest, and so we have the most information on it. And so generally, if you're having to choose something to start someone on for a first presentation during the first trimester, you choose fluoxetine. However, fluoxetine isn't such a good option in the third trimester because of its very long half-life, which is likely to stay on board baby and mean that it's more likely to have things like the neonatal adaptation syndrome. With the persistent pulmonary hypertension of the newborn, it's such a rare condition anyway that they haven't been able to look at any particular SSRI being more implicated. But the risk does just over doubles if you're on an SSRI during the 3rd trimester. Okay, so with lactation, generally with the antidepressants, they all have, well, the SSRIs have low levels in breast milk, or less than 10% the maternal serum level, which is the American Academy of Pediatricians' sort of cut-off point for medications being considered safe during breastfeeding. And of course, if the Americans say it's safe with their culture of litigation, then I think we can be pretty certain that it's probably okay. So we prefer not to use fluoxetine in breastfeeding. Paroxetine and venlafaxine have the shortest half-lives, so they'll clear from the baby faster, but tend to be more side effecty in mum. And so with the choosing of the antidepressant, I tend to choose it depending on what they've responded to before and also what sort of side effects you're looking for. So my 2 favourites are generally citalopram and S-citalopram, and if people are needing more anxiolytic effect, I would tend to use S-citalopram. And they've done some studies in New Zealand with regard to paroxetine in the baby of a breastfed mother, and it was Debbie Wilson did that in Christchurch, and I think they didn't find any paroxetine in any of the babies except for one who was prem anyway, and similar findings with citalopram and S-citalopram in Australia.
Can I ask you a question first? What's neonatal
Adaptation syndrome. Yep, that is basically shaky baby. And so I'll do a little demonstration for the cameras. So you know when you're holding a baby and you go like that, it will usually go like that. It sort of going to go like that, a bit more. They can also be less easy to settle, be either oversleepy or undersleepy, and can have feeding issues. But it's a short, self-limiting, I guess condition is possibly not the right word, that gets better and doesn't require any extra support. And although they talk about it like it's really, really common, I have literally seen only 3 or 4 babies who have the neonatal adaptation syndrome. And they're not sure still whether it's because of toxicity from being on the SSRIs in utero or whether it's withdrawal from not being on the SSRIs. So we really don't know, and that's why they call it neonatal adaptation syndrome.
And is citalopram safe in pregnancy? Or not?
Well,
so citalopram is the preferred one?
Well, that's the one which tends to be sort of okay all the way through. But when we say safe, we're looking at no one's proved it's safe, but no one's proved it's unsafe, if you see what I mean.
Yeah.
Yeah.
Thank you.
Yeah. So Sarah, so that's a slightly different medication you might choose for someone in the 1st or 2nd semester for depression. So would you ask them at that point, are they likely to breastfeed, or would that then influence, or would you switch people?
I guess I would, and this is, I guess, because when people come to me as a specialist, they've usually already been on fluoxetine.
Yeah.
And so I don't have to wrestle with, do I choose fluoxetine or not? Because it generally isn't one that you'd want to have on board later, although it's the one that there's most evidence for it not being teratogenic. Yes, there are lots of normals, if you like. But I do in practice tend to use either citalopram or S-citalopram.
And if they're on fluoxetine and are okay on that, you just leave them on that through breastfeeding?
Well, I'd leave them on it, but I would have the discussion.
Yeah.
And that's the good thing about having someone well, is that you can have the discussion. You can give them the information and direct them to websites that also have information. And I guess with women who have a past history, I would have these discussions before they even get pregnant. And for women on paroxetine, we generally look at switching to something before they even get pregnant rather than doing the swap onto something unknown. Yeah. Okay, so other antidepressants, tricyclics, which have been around now for almost 50 years. There were some concerns about limb reduction malformations with nortriptyline in particular, but those just haven't been borne out by meta-analyses. the benefits of tricyclics are that you can do blood tests to monitor serum levels and see if it should be working. And definitely a better option than benzodiazepines for sleep or anxiety. And the evidence in lactation, I say reasonable safety because some babies get a bit dozy and you can get urinary retention with them. The one study that they did in Australia comparing babies whose mothers were treated and they breastfed, treated and bottle fed, or not treated and breastfed. The babies whose mums were treated and breastfed ended up having better IQ scores at 4 than the other two groups. So I don't know that that's actually relevant, but it certainly showed that there wasn't any cognitive decline in babies who were breastfed with tricyclics. Other antidepressants, venlafaxine, bupropion, mirtazapine, I say caution because we haven't got huge amounts of information on them. With venlafaxine during pregnancy, back in 2004, just before a big international conference, there were 2 babies who had seizures after delivery, both on venlafaxine, both in the same centre. So, I mean, was there something going on? Because that's not something that's been consistently reported in the 10 years since that time. Many women feel that if something is natural and grown in the ground, that it's not going to be a problem. St John's wort is really common, is available in teas, all sorts of things. It acts as, it's a good antidepressant. It works like a monoamine oxidase inhibitor, which is one of the very old-fashioned antidepressants, which you wouldn't even consider giving someone during pregnancy. But that's how St John's wort works. So the other thing that it also does is it actually interacts with the other antidepressants. So it's always worthwhile just seeing if anyone's on any over-the-counter or store-bought remedies. They've done a very small study, I think 10 women who were breastfeeding on St John's wort, and there was an increase in gastrointestinal symptoms in the babies, but that probably wasn't statistically significant. So mood stabilisers are the difficult ones. With lithium, it's been around now for 60 years. There's an increased risk of Ebstein's anomaly, which is a serious cardiac malformation, from 1 in 20,000 to 1 in 2,000. So it's a 10-fold increase, but it's still not exactly common. The good thing is that there's been so much sort of examination of lithium that they've got pretty clear indication that that's the only problem that it's associated with teratogenicity-wise. And that if you know when she conceives, you can taper and stop and then resume again. And I've done that with quite a number of women, and it's all gone well. In later pregnancy, you do need to monitor serum levels, because particularly if she's got a fairly sort of fragile, I guess, control of the bipolar vulnerability. The last thing you want is her becoming unwell during pregnancy, and you generally need to increase the lithium level later on. So we suggest monthly monitoring in the 3rd trimester. And then during labour, you're looking at 12-hourly monitoring, because of course if you get dehydrated, you can end up with toxic lithium levels. And then not breastfeeding, because it's actually actively excreted into the breast milk, and babies can become toxic quite easily. With anticonvulsants, I would tend to generally, as a rule of thumb, not prescribe sodium valproate for women of childbearing age, just because it is so nasty. But some women have tried lots of other things and don't respond to anything but valproate. It has an increased risk of clefts and a whole lot of neurological possibilities. It does seem to be dose related though, so with sodium valproate, if you're on 1100 milligrams or less, you're much less likely to have problems than if you're on larger doses. And again, that's a discussion I would have with anyone who I end up resorting to having them on sodium valproate. I would have the pregnancy discussion with them straight up and look at other alternatives if possible. The good news is that now the atypical antipsychotics are readily available, and they are generally pretty good mood stabilisers. And although there's not a heap of evidence. The evidence there doesn't indicate any teratogenic effects of medications such as risperidone, quetiapine and olanzapine. And postpartum, for postpartum psychosis, olanzapine is one of my favourite medications because it's a mood stabiliser, is really good for psychotic symptoms and helps you sleep. They seem to be minimally excreted into breast milk, although there are concerns about metabolic effects and sedating effects on the baby. So again, it's on a case-by-case basis. The problem is, if you're treating someone with postpartum psychosis, their insight and ability to give informed consent isn't going to be as good as someone who's fine, who you're discussing forward planning with. So for someone who has bipolar disorder or has a past history, even discussing what sorts of medications, what the evidence is around them, is something that you can do, or refer them to the maternal mental health service to do before they become unwell. Clozapine is an interesting one because it's one of the more toxic medications that we have, requiring monthly blood tests forever. But it's been looked at very carefully during pregnancy and actually has a B rating, whereas most of the other psychotropic medications have a C rating because it's been so carefully looked at. Benzodiazepines are not nice creatures. There's an increased risk of midline clefts if given in the first trimester, and if taken by mum in the second and third, what are described as soft neurological signs in baby, and also increased risk of apnea and floppy baby syndrome. I prefer not to use them in lactation, but you can pump and dump with short-acting hypnotics like temazepam. Zopiclone, there's very little written on what that does during pregnancy or postpartum, but it sort of appears to be given out like Smarties. My preference, if someone really needs something to assist with sleep, is to use very low-dose quetiapine or to use a tricyclic, because we have a lot more evidence on tricyclics, and the dose of quetiapine that you'd be using is so low, like 25 milligrams, when the therapeutic dose ranges between 400 and 800, so looking at tiny, tiny little amounts. The other possible hypnotic that you can use is an over-the-counter, easily purchasable one called, what's its name now? Sleep gels. Anyway, diphenhydramine. Unisom sleep gel is its brand name, but diphenhydramine is a antihistamine that's been around for a long time and has an A rating, so that's another possibility. Or having a warm, not hot bath, or warm milk, or chamomile tea, or doing some mindfulness are all good things. So, just general things. 50% of pregnancies aren't planned, so you need to be aware that your woman of childbearing age between 12 and 50, say, might be pregnant or might get pregnant without meaning to. Avoiding the anticonvulsant drugs, particularly in the first trimester if possible. Try and use one thing if you can. Other substances and other drugs, I guess I should have written herbal products and things in there as well. And I guess the main overall thing is aim for her being well at the time of delivery. So, I guess, should it be changed if she's taking paroxetine? Preferably, but if it's the only thing that she's responded to and she's willing to take the risk of there being a heart issue, of being a septal defect, or having a scan, a careful anatomical scan at 20 weeks. Talking about, I guess if someone's had postnatal depression, they've done well with an SSRI, and they're looking at wanting to get pregnant again soon, what do you do? Because generally we need to look at treating for a year after a postnatal depression, because otherwise people tend to relapse. The other thing as well is that in a study they did in the UK about prevention, where they started people either on something that they had responded to before or a placebo, they actually had to stop the study because the women who were on active treatment weren't becoming unwell, whereas the others were falling at the rate of 1 in 3, as you'd expect. So they had to stop it because it became unethical. It reached statistical significance fairly promptly. The question of should SSRIs be tapered prior to delivery, it probably does reduce neonatal adaptation syndrome, but you're actually hemodiluting anyway because you're getting, hotter, fatter, wetter, tireder as you get more pregnant. So you're actually getting a reduction anyway. And is it really sensible to reduce someone's medication that's keeping them well just when they're about to be at the most vulnerable time of all? But again, that's a discussion to have with the individual woman. And there was a reasonable study about what happened to women who stopped SSRIs just because they were pregnant. And they got unwell reasonably frequently and ended up having to have more medication plus things like benzos or antipsychotics. But if a woman has a recurrent depression, including psychosis or suicidal ideation, you really just shouldn't look at stopping.